Thank you, Mike, for your kind introduction and remarks. Good afternoon, ladies and gentlemen. I'm very privileged, honored to be appointed as the speaker of this Helen Rollason Memorial Lecture. Professor Primrose sent me the list of the previous speakers, which really terrified me, and I respect his decision to send invitation to the Orient and non-English speaking country, especially the Japan, which is infamous for poor English speaking. And I like to do my best not to betray his expectation and be as exotic as possible. I will do. And my talk is gastric cancer, always gastric cancer, with special reference to education and training. First, I'd like to give you a rough sketch of training system of surgeons in Japan. We have Japan Surgical Society, JSS. It was since 1899, and it's not equal to Royal College of Surgeons, because we have many junior members there. As soon as you graduate from medical school, and if you want to be a surgeon, you can join this JSS. So we have now nearly 40,000 members, and among them, the board-certified specialists are 21,000. So big members, and 21,000 specialist members can say they are surgeons, certified surgeons. And for this JSS qualification, you need some clinical training and also some academic presentations. The registration first at JSS, okay? And then you receive training at JSS certified institutions for at least 4 years. Then you take the written examination, and after a year, you take the oral examination, and you send the documents about your presentations in JSS certified meetings or journals. And journal papers are not mandatory, but this certified meetings presentation is necessary. And the surgical requirements include 350 cases at least, among which 120 as operator. And GI and abdomen surgery has the largest number among them. This year, just 4 weeks ago, we had the annual congress of this JSS at Kyoto, surrounded by the full cherry blossoms. And during these 3 days meetings, we had 14,000 participants, consultants and junior surgeons, and we had 3,000 presentations, including half posters, mainly by junior surgeons, and in the 17 parallel sessions. And in order to feed all these participants, we need 47 luncheon seminars. So this is really a big event for Japanese surgeons. And yes, it's a festival, kind of. But there are many, many presentations about research or the clinical trial results and so on. And in this Congress this year, we had a special lecture by Professor Yamanaka, who is a Nobel laureate. And he talked about ES or iPS cells. And the main hall was packed with these surgeons, especially senior surgeons who don't understand at all the genetics, but just wanted to see the Nobel laureate live. Okay. And it was a big event this year. And besides this basic JSS, we have several subspecialty organizations. And for GI surgery, we have the Japan Society Gastroenterological Surgery, JSGS. It is relatively new. Now we have 21,000 members, among which 6,000 have the board-certified specialists. This is rather small because this board certification system is rather new in this society. And in order to get the JSGS qualification, first you should be the JSS certified surgeon. This is the basic requirement. And you should finish 7 years training at certified institutions. And 45 cases are minimal requirement of surgery, including 15 gastrectomies and 15 colorectal surgeries and so on. Okay, now let's move on to the education training for gastric cancer specialist. Gastric cancer is a special disease. This is the latest global count data and incidence rate of all cancers, okay, all kind of cancers. The North America, Europe, or Australia, these are the countries where the incidence rate is very high. These are all kind of cancers, but gastric cancer, look at this. This is totally different distribution. I'll be back. This is all cancer, and this is gastric cancer. Completely different distribution, and especially in Eastern Asia, China, Japan, Korea have the highest incidence, and we have actually 60% of all new cases in these three countries. So gastric cancer in Japan is a bit different from gastric cancer in the UK, and it's most common malignancy, and it's curable cancer because half of the new cases have T1 tumors, early gastric cancer, which can be removed either by endoscopy or limited surgery. And 5-year survival of all cases exceeds 70%. So in Japan, gastric cancer is the disease to be treated at any hospital and surgically curable disease. Actually, we recently started the National Clinical Database System, and the first report in the first year, 2011, included total gastrectomy results. We had 20,000 cases of total gastrectomy in this year in all over Japan, and 30-day operative mortality was 0.9%, and hospital mortality within 90 days was 2.2%. As compared to our JCOG clinical trial, total gastrectomy with or without splenectomy, this mortality was rather high, but still it's acceptable because our patients are all selected patients and operated on in the specialized institutions. So this is the Japanese reality. Okay. And let me talk about a bit of history of gastrectomy to explain why Japanese surgeons cling to lymphadenectomy so much. Okay, cancer staging concept is not so old. French surgeon Pierre Donois invented this TNM classification just 60 years ago. And UICC adopted this TNM in 1953. These are based first for breast cancer and laryngeal cancers, and then extend this system to all solid tumors between this period, and finally published the first pocketbook, Livre de Poche, in 1968. But before this, in Japan, we have already established the classification of gastric cancer. First edition was published in 1962. So this is independent from TNM classification or American Joint Committee classification. And since then, we have the separate revisions, but now combined together. These are the founders of the Japanese Research Society for Gastric Cancer, all these big surgeons at the time. And they not only defined the treatment method, but also the handling of the resected specimens, how to open the resected specimen, how to place, always the proximal part on the right side and distal part on the left side, and how to cut the specimen or measure everything. And according to these rules, almost all gastric cancer cases have been recorded in Japanese database. This is an operative note written in 1964, exactly 50 years ago. Surgeons sketched the tumor and placed the lymph nodes dissected in the original position and examined, compared with the final pathological report, examining which lymph nodes are involved from what kind of tumors. This kind of data have accumulated for over the past 50 years all over Japan. We gave the station numbers to these lymph nodes up to these para-aortic area. And the young surgeons, the first step for them is to memorize all these numbers. Otherwise, they can't discuss surgery with their seniors. And we examine the lymphatic flow from the stomach. We inject the dye in various parts of the stomach and trace these lymphatic flow. And we knew that these perigastric nodes are important. Then the second level nodes are important, and then para-aortic number 16 nodes are very important. And most of lymphatics gather around the celiac artery, then enter the para-aortic lymph nodes, then enter the systemic circulation via the thoracic duct. So we considered that number 16 para-aortic lymph nodes are the final regional lymph nodes from gastric cancer, and developed the para-aortic nodal dissection technique, PAND. And until this time, simply we collected the data and went straight. There was no evidence. There was a big dogma of Japanese cancer surgeons saying that lymph node metastasis is local disease. Okay? And local failure is surgical failure. So it's a shame to have the local failure. The more, the better. Of course, there's no evidence for this, and so we just tried to show the evidence, produce the evidence by randomized clinical trial, control trial, and we started the JCOG 9501 D2 versus D2 plus para-aortic nodal dissection. We recruited patients with adenocarcinoma non-early, and during the operation, the large cytology should be negative. Then we intraoperatively randomized them into either standard D2 gastrectomy or D2 plus para-aortic lymph node dissection. And we observed the patients without adjuvant chemotherapy because in this period there was no evidence of adjuvant chemotherapy. We collected 500 patients in the specialized institutions and follow-up. And very disappointingly, the two survival curves completely overlapped. Okay, overall survival was good, but no definite benefit of D2 plus PAND. This PAND is not for the swollen nodes. Okay? This is only for prophylactic purpose, so no clinical swollen lymph nodes. But we are bad losers. You may call us bad losers because we interpret this JCOG trial that prophylactic PAND has no benefit, okay? But para-aortic nodes are not regional nodes, okay? So regional lymphadenectomy D2 is still necessary. Okay? And also, PAND may have a benefit in multimodal therapy for gastric cancer having extensive nodal disease. Like this. Okay? So we started some phase 2 studies for extensive lymph node metastasis. First, we collected the data retrospectively among the participating institutions and found that in the bulky N2 lymph nodes, large lymph nodes around the celiac artery or common hepatic artery, then 3 or 5 year survival rates after R0 resection was 4% and 13% very poor. And the patients with CT swelling of para-aortic lymph nodes, even after R0 resection, 3 year survival is only 5%. So, for these patients, we conducted phase 2 studies using neoadjuvant chemotherapy. And first, we make the staging laparoscopy to confirm no peritoneal disease, negative cytology. Then 2 or 3 courses of neoadjuvant chemotherapy was given, followed by the D2 plus para-aortic lymph node dissection. The first regimen was CPT-11 plus cisplatinum. We collected 55 cases, and the overall survival, 3 year survival, was 28%, which was better than historical control, but not yet satisfactory. So we changed the regimen into S1 plus cisplatinum. This is now the gold standard for unresectable gastric cancer in Japan. And surprisingly, the 3 year survival reached nearly 60%, and recently the complete 5 year follow-up was just published in British Journal of Surgery, and this is 50%. So this was amazingly good results, and now in Japan, this neoadjuvant chemotherapy followed by D2 plus PAND is the tentative standard treatment for this bulky nodal metastasis disease. Now discussion is whether para-aortic nodal dissection is really necessary for this chemotherapy group. Some people say that D2 is sufficient because bulky node is already systemic disease, and if patients survive, that means it's due to chemotherapy effect. So surgical invasiveness should be minimal. But some people insist that complete local control is important, particularly after a good effect of systemic chemotherapy. So we should perform D2 plus para-aortic lymph node dissection. Now we may start the randomized trial between them. So in Japan, we have our own way to establish evidence for gastric cancer. And always the base is this database of lymph node metastasis and survival, which have been accumulated for over the past 50 years according to the same standard. And we developed endoscopic mucosal resection or endoscopic submucosal dissection and D2 gastrectomies. These are for early cancers, no randomized trials. We slowly tested this, and it was very good. So we go back to the database again, and we are now trying to extend the indications of ESD. And we cannot perform randomized trial between ESD and surgery. So now we are conducting a confirmatory single-arm phase 3 study. For surgery, we performed several randomized trials. Bursectomy, it's going on. Splenectomy, soon we'll have the final results. And PAND, as you see, we couldn't show the benefit. Now it's in the phase 2 level for NAC, neoadjuvant chemotherapy plus PAND, and then we may advance to phase 3 study. So now, D2 gastrectomy, I should say it's technically demanding procedure, okay? Because, in order to explain that, you should go back to the embryology. This is a 5th fetal week diagram. Stomach is here, and dorsal mesogastrium. This includes everything: celiac artery, splenic artery, left gastric artery, even the spleen and the most of pancreas arise in the dorsal mesenterium. So, if the tumor is here, and if you plan the complete unblocked dissection of the organ, you should remove all the spleen and most of the pancreas together, but it's impossible. Unblocked dissection of the gut is different from colon and stomach. And for colon, it's easy. You can cut the origin of the artery and you remove everything. But in the stomach, the antrum and duodenum, pancreas, vessels, and so we cannot remove everything. We should carefully remove all these lymph nodes, avoiding the injury to the pancreas. And the proximal part, you see the pancreas and splenic artery, and this dorsal mesogastrium or greater omenta. These includes all the lymph nodes, so the lymphadenectomy, preserving these organs or arteries, and sometimes removing this membrane, performing bursectomy. These are necessary, and this is not easy at all. By the way, the concept of bursectomy was first proposed by the British surgeon Ernest Grove in 1910. He's from Bristol General Hospital. He wrote that the largest lymph-bearing area connected with the stomach is in the great omentum, and from this the lymph vessels loop back in front of the transverse colon here, above the transverse mesocolon to the peritoneum in front of the pancreas, ending in the lymph glands around the celiac axis. So these dotted lines should be removed in gastrectomy. This is exactly what we call bursectomy, omentobursectomy, but this proposal was not accepted or survived in Europe or in the West, but in Japan we continued to this technique. So anyway, for D2 gastrectomy, anatomy is very important. Now, if you perform only simple gastrectomy, it's not very important, but particularly for this dissection, lymphatic spread, omentobursal structure, or vessels of the pancreas and the spleen, you need to know all these anatomy. And in order to understand this anatomy, embryology is always very important. The problem is that embryology is difficult to understand or memorize. And I'm not a good medical student. I skipped all lectures and I don't understand very well. But recently we are very lucky that we have a very good textbook, Illustrated Surgical Operations by Dr. Shinohara. This guy, he's not a barber, he's a surgeon. And he looks young, but he's 49 years old with very good experience of GI surgery. He's very active in Toranomon Hospital, Tokyo. And if a gastrectomy in difficult case went well, I celebrated by drinking wine, champagne. But Shinohara wrote a diagram to show this. And his textbook was published in 1994, and now a third version was published, and 30,000 copies were already sold. This is a kind of Bible for young trainees of GI surgery. A lot of beautiful diagrams, illustrations. And I will show you some of the series of his diagram. Not to explain you the detail of embryology, but I like to show you how easy to understand with his illustrations. If you cut this level, then the aorta is here, liver is here, stomach is here, then the rotate starts, and this will be the bursa mentalis, and then the rotate continues up to 180, and then this part, the pancreas will attach to the, make the total fusion fascia with retroperitoneum, with these lymph nodes to be dissected here, and a further rotation, then the formation of Henle's loop here, and this transverse colon will be attached with a greater omentum, and greater omentum then further expand 3 dimensions, and now with this big omenta, you can see the bursa mentalis here and double mesentery is here. And if you cut this surface, when you perform no omentectomy, simple gastrectomy, you enter here, but you perform omentectomy, you cut here. If you perform omentobrachectomy, you come here and here. So this kind of illustration is included in the textbook with a surgeon's point of view, and it's very easy to understand. Again, this is a good guide, and the textbook is already available in Chinese and Korean, but not in English. And I wonder if some British publisher is interested in this. Now, so training of D2 gastrectomy is facilitated by this textbook, but it's not easy. Demonstration of surgery is always the important part of surgery training. And the first successful gastrectomy was done by Theodore Billroth in 1881. And demonstrations of surgery has been always very important. And in Japan, we had the genius cancer surgeon, Dr. Kajitani, in Cancer Institute Hospital, where I am now working. He continued to operate on cancer patients just before his death at the age of 83. And many Japanese surgeons come to Cancer Institute Hospital only to observe his operations every day. And training for gastric cancer surgery in Japan is basically watch and learn, or in old Japanese saying, watch and steal, okay? Steal the technique. This is a traditional apprenticeship code of samurai we call bushido, okay? And so we don't tell a lot, simply we watch carefully and learn. And it hasn't changed a lot in surgical world. And Japanese Gastric Cancer Association, we have no certification or curriculum for gastric cancer surgeons. So the training system is left to individual institutional program. Actually, watch and learn is not easy. Okay, this is my operation, 2 assistants, other observers. Only this guy can have the same vision with or share the same vision with surgeons. And we have some curriculums in gastric surgery division, Cancer Institute Hospital, Tokyo. Our division includes 5 staff surgeons, including a senior vice director who is not clinically active, and 7 residents. And we perform 600 gastrectomies per year, among them half are by laparoscopy for T1 tumors. And our residents stay with us for 2 or 3 years. And they are first JSS certified or JSGS certified surgeons, so at least 5 or 6 years experience, but various degrees of experience. Open gastrectomy, 5 to 30 cases. Most of them had no experience of laparoscopic gastrectomy. And for open gastrectomy, T2 to T4 tumors, mainly, we staff surgeons operate on patients, and the the newcomers, first 5 to 10 cases, they assist us as the second assistant, and then the first assistant, and then we sometimes let them operate, and we teach and change and so on. So during 2 years training, they perform 20 to 40 open gastrectomies for advanced gastric cancer. It varies among their technique or maturation or qualifications. And laparoscopic gastrectomy is a hot topic, and our center has the largest number of experience in Japan. It's strictly confined to T1 tumors now. And at first, they start as a scope operator. Okay. First 40 to 50 cases. It's very big numbers, but anyway, we have so many cases, so the newcomer spend a lot of time to showing or watching himself by scope. And then the assistant, then start to operator, then assistant, operator, assistant, and during 2 years, they operate 30 to 40 cases laparoscopy. So in total, 60, 80 gastrectomies during 2 years training period. And in laparoscopic gastrectomy cases, if they are lucky, they can apply to the certification of Japan Society of Endoscopic Surgery, sending the anonymous, unedited videotape. And apart from this institutional training, we organize some gastrectomy workshop twice a year for other institution people. We usually invite 18 to 20 junior surgeons of general hospitals all over Japan. And it's a 2.5-day course. And day 0, we give the lectures of anatomy, procedure, or videos. And then day 1, we have 2 open gastrectomies and 2 lap gastrectomies. And surgeons carry the microphone and the video monitors and explain everything, interactive. And in the evening, we review the video and discuss the case. And on day 2, again, 2 lap gastric surgery. And when they leave, they have the souvenir of all DVD of these courses. The workshop is like this. Now I'm operating here, the professional video setting is here, and the 8 to 10 people at the time are now in the room observing directly the vision or these monitors, and they discuss. And our resident assists the discussion. I am here and answer the questions. And this video system, the quality is now very good. And you can see very clearly, sometimes more clearly than the naked eye, these structures. And so viewing all these images, we can discuss during workshops. And finally, they bring these videos back as a DVD. So, D2 gastrectomy is, of course, important in the world, we think. In the Dutch trial, as you know, they have final 15-year results. There was no difference among the overall survival, but they found that the death due to gastric cancer was statistically significantly fewer after D2 than in D1. So they finally concluded that D2 lymphadenectomy is the recommended surgical approach for patients with resectable gastric cancer. There is another important D1, D2 negative trial, MRC trial here in the United Kingdom, and D2 had very high operative mortality, 13%, and the survival curves never crossed. But recently, Professor Kushieri, and the principal investigator, wrote a letter to the editor of Annals of Surgery. He says that as the principal investigator of this MRC D1, D2 trial, he believes that the results of the trial are no longer a sustainable argument against D2. We should also recognize that, like everything else in life, randomized controlled trials have a sell-by date, and that pertaining to the MRC D2 gastrectomy, the trial has now expired. This is a very brave announcement, and I respect this very much. Anyway, now, the D2 resection without splenectomy and distal pancreatectomy is officially recommended by the ESMO guidelines, and also in American NCCN guidelines. There's a discussion that in the West, D2 dissection is considered a recommended but not required operation. And it should be performed by experienced surgeons in high-volume centers. The problem is that in the United States, there are not many experienced surgeons in high-volume centers for D2. So on the whole, this NCCN guidelines recommends D2, but actually they perform D1 or D1+. We need D2 gastrectomy course outside Japan. So Royal College of Surgeons England have the course between 2002 and 2009. Richard Hardwick, Cambridge, was the convener, and Professor Griffin and Professor Alderson also participated as a faculty member, and I regularly participated, and this was very interesting. Now it's finished in the Royal College of Surgeons, and it's moved to Scandinavia. And since 2011, we have the Nordic D2 gastrectomy course, very similar to this Royal College of Surgeons one. And in this course, the fresh cadaver resection was tried. I have to comment something about laparoscopic gastrectomy. It's a big wave now, of course. And this laparoscopic gastrectomy, I have a special position for this. I am now the chairman of JGCA guideline committee. So as a chairman, I have to insist that LAG should be regarded as investigational treatment and be prospectively assessed. It's not the standard yet. And I have to insist that the cautious, slow progression of this study. So Japanese young lap surgeons regard me as the representative of resistance force, old guard, or dinosaur. So, I have to say as a dinosaur, but I have really some concern about LAG, especially for advanced gastric cancers. It's a possible impairment of surgical perfection that we tried over the past 100 years. Intraoperative diagnosis. Can we diagnose disease extent with the same accuracy as in open surgery? Or can we treat the stomach as gently as in open surgery? We may stick around all the stomach together with the tumors. So there are several issues to be addressed as for this laparoscopic gastrectomy for advanced gastric cancer. Nevertheless, I think that lap surgery should be regarded as one of the greatest technical innovations in the history of surgery. So in the training, the many advantages. There's only one single image everybody watches and shares, and everything was recorded. And dry lab training is also very efficient, especially for young people. And they have a big motivation in Japan to be certified by Japan Society Endoscopic Surgery. This is very difficult. And new technique or new devices are immediately and accurately diffused. There are a few disadvantages. There's no voice recording system, so it's difficult to understand what they are doing only by videos. And more people, lose their interest in open surgery. This is terrible. In our institution, residents gather once a week after work and review all these videos, fast forward, and senior residents teach junior residents how to assist surgeons because this surgeon has some special technique at this point and so on. They continue this almost every week, and they review almost all cases, and this cannot be performed in open surgery. So it's a big advantage. So in order to learn a master surgeon's technique in the past, you have to travel all the way to the master's theater and get the best position to watch the surgery. Okay? But today, in lap era, you may travel, of course, all the way, but you don't have to. And you watch the large monitor sharing the same image, exactly the same image with the master, and copy the video and review it repeatedly. As for D2 lymphadenectomy, in the past, if you say, I always perform accurate D2 lymphadenectomy. Okay, I see. Really? But there's no way to test it. But now, in Lapo era, if you say, I always perform acute D2 lymphadenectomy, then young people will gather, wow, great. Which style? The left approach, middle approach? Which do you attack first? U-curve, V-curve? It's, it's very special terms for themselves. Show me your video. This is the definite question. So now everything is changing by introduction of laparosurgery. I once tried to introduce this video recording system in open surgery. I found a very small, high-resolution camera. I tried this. And, with this camera, you feel as if you are a surgeon, okay? But a bit heavy. And when your head or neck is, tired, you may relax your head and everything moves quickly, and it's not very good for the recording. And so I gave up, and instead we established some video or recording systems for open surgery. This is a specially designed arm for a very good video camera, and it can be controlled from outside. And I'm operating here, and the residents are assisting me, okay, and the camera is just here. And recently, these residents, they want to look at the monitor directly, not the direct vision, but prefer the monitors. But it's not very good. And so, hey, look at this, I say, but they always look at the monitors. And this is also very useful for training. The senior residents explain this on site, and of course we can interact everything. So now I'm trying to record as many cases as possible. And of course this system can be used for reviewing for residents as in laparoscopic surgery. They fast forward the film and check everything, but still the angle is a bit different from surgeon's own angle. I think this should change. This would change the training system in Japan. So, ladies and gentlemen, in conclusion, there is no standardized national training or evaluation program for gastric cancer surgery in Japan, unfortunately. We should develop that. The gastrectomy with D2 lymphadenectomy is technically demanding, and training should be given in special curriculum in specialized centers. And intensive workshops are currently available in various parts of the world, most effectively in Japan. If you like, now we are planning to extend this to Asian levels, inviting Asian gastric cancer surgeons. And laparoscopic surgery provides innovative educational effects and has the potential to completely change the training system for cancer surgery. Thank you for your attention.